Next up, we have Dr. Ravi Brar. Let's see, she has an MD and MPH. So she got her Master's of Public Health at Dartmouth, and then went to med school at Virginia Commonwealth University, stuck around in Virginia for her residency, ortho residency at the Medical College of Wisconsin. Then she did her Peds Ortho Fellowship in Atlanta, at Atlanta Scottish Rite Children's Hospital. And she's been with us at UCSF since 2016. Let's see, 3 years ago, was it 20? She's also got this title of being the medical director of UCSF's CP and Spasticity Center, which is really cool. And she's my go-to person for neuromuscular ortho things.
Thank you, Mai. I gotta say, Mai's like the best hype person ever, too. So I'm really happy to work with her and our entire rehab department. So in general, I put too many slides and too small of font. So I apologize for that. I did cut out like 15, there's still too many. And thank you all for still being here. It's a beautiful day out, and we're talking about complex things in the afternoon after lunch, so I know it's hard. But yes, I'm Ravi Brar. I'm an orthopedic surgeon. I have no financial disclosures, but UCSF is a member of the Cerebral Palsy Research Network, and most of us are members of the American Academy for CP and Developmental Medicine. And since there's gonna be a lot of people talking about CP and neuromuscular conditions, I'm gonna quickly go through the definition and highlight what's important like throughout this talk for orthopedics. So cerebral palsy is a static encephalopathy. That's what everyone's taught. But what we care about in ortho is that it has progressive effects on the musculoskeletal system that affects like movement, tone, and posture. And so it's heterogeneous effects, and the clinical manifestations are all dependent on the location and severity of the parts of the brain that are injured. So I'm gonna adjust some things over here so I can see better. CP affects muscle size, composition, and force. And so it's all a vicious cycle on your skeleton. There's abnormal neurological signals and spasticity that results in the muscles being fewer, shorter, and stiffer, the fibers of them, and then a longer tendon. So then you have a weaker muscle with diminished excursion and a decreased cross-sectional area, which leads to decreased joint range of motion and decreased power. The smaller, stiffer, weaker muscles also don't have good selective control. It's worse in the muscles that cross two joints, your biarticular muscles. And there's a discrepancy between muscle growth and bone growth, which can lead to more weakness, deformities of your bone and your joints, loss of function, and pain. Muscles, this is a cycle I'm talking about. They need a stretch stimulus to grow. And so if you have a motor delay or joint contractures or tone abnormality, it limits your physical abilities that provide that stretch stimulus. So then you have inhibition of your normal muscle growth and development. And there's a mismatch between the muscle strength and the person's body size. And as they grow, they can have a heavier body and worsening joint contractures and worsening weakness. And so that's why we see during the adolescent growth spurt that patients who are ambulatory or have a certain level of function can sometimes decline in their function and lose the ambulation potential. And so that's the natural history, unfortunately, in some kids for that deterioration of gait during adolescence. So what can orthopedics do? Well, we can help with anatomic issues. When it comes to soft tissue, we can address tight tendons. There's often a muscular imbalance where something like the adductors are stronger than the abductors, and we can address that imbalance by weakening the stronger one. We can address contractures, torsional abnormalities, limb malalignment, and some dynamic issues when it comes to gait. What can we not do? We cannot improve strength. You just heard me say when there's a muscular imbalance, I don't do something surgically to make it stronger, I just weaken the stronger muscle. So physical therapy is what can help with insufficient strength. I can't correct issues with balance, such as ataxia or the brain's inability with proprioception to control that balance. I cannot improve selective motor control. And unfortunately, we can't improve the communication between the brain and the muscle. So anything I do is not going to increase or decrease tone. The way we talk about cerebral palsy and communicate to each other is about the has to do with the gross motor function classification. And so to distill it down, there are 5 levels, and since CP affects kids to different extents, this is how we communicate it, and this is also what affects prognosis. So those who are level 1 are high functioning. They can walk, run, and jump without issues, but sometimes there's a little bit of like decrease in speed or balance or coordination. Level 2, that's when I ask kids, like when you walk upstairs, you have to hold onto a railing. Can you take a hike on uneven ground and not have issues? 3 is that turning point where they use an assistive mobility device. Those who are level 4, so are more impaired, can sometimes walk short distances with a walker, but are still reliant heavily on wheeled mobility for community ambulation. And then our GMFCS5 kids are the most affected, and they often lack head and trunk control, and there's no independent mobility. Neuromuscular acquired hip dysplasia. This is something orthopedics cares a lot about. And the pathophysiology of it is that the spasticity or dystonia and the lack of the muscle control causes abnormal imbalance of the muscular forces across the joint. And the illustration that you see on the right there is showing how you have a normal hip on the left and an abnormal one on the right, and how the imbalance of forces are causing the joint like acquired dysplasia. So the adductors are pulling the leg in and causing it with the tight flexors to sublux out. And as that femoral head is being pulled up, it's causing lateral pressure on that acetabular roof. And so instead of that nice round socket, it keeps getting hit by the femoral head, which then causes it to be more vertical. So then you don't have a nice deep socket. You have increased aneversion, you have increased neck shaft angle, and then with that femoral head constantly abutting unevenly the socket, then it gets deformed as well. And so you no longer have that nice round head. You can have a windswept pelvis, which the dislocation, which then causes pelvic obliquity, which as we know, can then contribute to neuromuscular scoliosis. The risk of hip subluxation and eventual dislocation is directly correlated with the GMFCS level that we just discussed. It's a pretty significant relationship. It's linear and it's directly proportional. And so to me, that means that any child with CP gets a pelvis x-ray, even if they're high functioning, just as a baseline. And so throughout childhood, the total risk for displacement for GMFCS5s is about 90%. GMFCS4 is about 80%. So that's pretty significant. And that's why hip surveillance is kind of like my soapbox. So why is this all important, especially if a kid even if a kid doesn't walk? Because a located hip, a hip that is in the right place where it's meant to be, moves better and is less painful than a hip that is not where it's supposed to be. And even if you don't walk, it's a stable platform for sitting. And if it's in the right location, then you're able to maintain that motion and what activity you do have with aging. When it does sublux or it does dislocate, some kids don't have pain, but many do, especially if it was in the right place to begin with, because then your femoral head is abutting a part of the pelvis that it's not supposed to hit when you open the hips to, say, put on a diaper. So I think it's a huge problem even in our kids who don't walk. And dislocation and subluxation, it causes that misshaped femoral head or that misshaped socket. And so when you have two shapes that don't match, that's arthritis and stiffness and pain. And it makes it really hard to take care of the kids on a daily basis who can't advocate for themselves. Why do all the ortho people have issues with working the computer? I don't understand, I'm sorry. So this brings us to hip surveillance. And so hip surveillance is just monitoring the hips regularly to identify early indicators of hip displacement, and that's with regularly scheduled physical exams and x-rays. And this matters even in kids whose hips don't hurt, because even though they have good range of motion now and no pain now, it doesn't mean that they won't have pain in the future. So you want to be able to catch it early. And the goal is to treat or prevent pain with this early intervention, and we can improve outcomes and reduce the number of reconstructive surgeries, and also reduce the need for future salvage surgery, because salvage, as it implies with that name, is not a great surgery, but sometimes it's our only option. So there are three main components to hip surveillance. It's ideally a population-based targeted evaluation, and in other countries, everyone participates this, from the physical therapists, the rehab physicians, the general practitioners, everyone's involved. But we in the US don't have as coordinated of an effort, unfortunately, because we have such a heterogeneous population with our different states and everything. But even within California, we don't have a nice surveillance program. But it's regularly scheduled physical exams and radiographs, and the frequency of that is based on the GMFCS level. On physical exam, as Dr. Diab was saying, we just like to eyeball certain things. And so for me to start delineating GMFCS level, I'm looking at head control, their ability to sit on their own. And then I'm asking about difficulty with diapering. And then I actually ask parents how they change a diaper, because they'll say they don't have an issue because they've been changing this child's diaper for 15 years. And then you'll see them wedge their body in between the knees and somehow change a diaper. And that is not sustainable as the child continues to get stronger and older. And so I think it's an important thing to ask, because just because they can get by doesn't mean it's the right way to be doing things, and it's going to be harder in the future. I look for asymmetries, pelvic obliquity, any limited range of motion, and skin breakdown, especially from any braces and rotational abnormalities. When it comes to referring to orthopedics on your physical exam, if you find that hip abduction is less than 30 degrees with the hips in extension, so not flexed up, refer to us. If you see hip abduction is asymmetric, please refer to us. If you notice that the hip abduction is decreasing, please refer to us. And if hip extension is decreasing, please refer to us. Oftentimes, it's hard to get the right x-ray for an AP pelvis because of the lordosis in the lumbar spine. So sometimes we have to ask our radiology techs to put bumps underneath the knees to deal with contractures to get that right x-ray, and it does matter. I even have this printed out at our x-ray room so that people know what we like. But all you really need for routine surveillance is the AP view, because that's how we do all our measurements. We want the legs parallel, we want the kneecaps, the patella facing up, and we need to reduce the lumbar lordosis. The migration percentage is what tells you how uncovered that hip is, how much it's migrating out of the socket. And what you can see in this example, it's the same child. And in infancy, the hip was normal at about 18 months with only a 10% migration percentage. At 1 year, or 1 year later at 2.5 years, it increased to 25%. By age 5, it was 40%. And then age 8 and on, you can just see how it got progressively worse and deformed. In that last photo, there's severe acetabular dysplasia where it doesn't even exist, the socket. It's just like this wall without any concavity to it. And you can see that there's just a chunk missing out of the femoral head laterally there, because there wasn't the forces from the acetabulum for it to grow and to form that nice round head. When it comes to x-rays, please refer to orthopedics if the x-ray shows a migration percentage greater than 30%. And so you might be thinking, well, I don't want to do calculations on my x-rays and draw lines and then do a division with the calculator that you bring up on your computer, which is the same thing. I don't want to do that either. And so Dr. Kulkarni, an orthopedic surgeon at the Shrine in Sacramento, developed this free app on your phone. And this is what I use every day. So the other day I forgot my phone, which besides that being my pager and being a problem, I couldn't do my migration percentages, and I was literally at a loss pulling up the calculator and like drawing lines and dividing. I hated it. So this thing's amazing. When you have a chance, download it for free. It's cool because it also shows you guideline summaries, like frequently asked questions. It has that protocol for how to get the proper x-rays that you can print out and put somewhere. And so what you do is you just pull up the x-ray, you take a picture in the app, and then you have these horizontal lines, and that's for rotation. So many of the kids are not gonna lay like perfectly straight, and so you just rotate it to get it as level as possible. I use the triradiate cartilage or like the bottom of the ischium to get it level, and so you rotate using that. And then you zoom in on either side. And so that red box exists because once it hits the red box, and what you're looking for is the lateral edge of the bony acetabulum. If it's within that red box or touching the red box, so inside it, refer to orthopedics. Because that red box is 30%. So each line here is 10%. So that's why the red one is the third one. And so if you look at this bottom one here, what you do is you line up the black line on the medial aspect of the femoral head and the white line on the lateral aspect. It's hard to see it sometimes because this kid's, like the lateral aspect is not easily seen because it's not getting the right contact pressure, so it's not developing as well. But you line it up and then you can count here, and that's a 70% migration percentage. So it makes it really easy and quite fast. So I highly, highly recommend this app. And it's an award-winning app and everything. I alluded to this earlier. We need organized hip surveillance. There's nothing nationally, there's nothing within California, but Australia, some European countries, British Columbia, they all have surveillance programs led by primary care physicians and therapists, rehab physicians, orthopedic surgeons as part of their evidence-based care. And that has resulted in like not having salvage surgery. So kids aren't getting their hips cut out because they're so deformed. And so that's a huge deal. And I think since other people can do it, it's something that we should be lobbying for to get more attention to it through our CCS clinics and things like that. But it's really hard to organize, but I'm just constantly on a soapbox about getting x-rays about the pelvis because as an orthopedic surgeon, I am single-minded when it comes to the hips, and I'm quite aggressive about it. But I think it does make a huge difference. Your surgical options when it comes to hips are soft tissue and then bony procedures. So you can have your soft tissue lengthening in your releases, and so this is an adductor tenotomy. I do open, I know there's percutaneous, but I do open because I feel like you can really lengthen it well, and you do graduated releases. If it's not enough to just get the adductor, then you just keep doing more, including the gracilis and abductor brevis. And so this is a kid who had really had a lot of spasticity at 2 years old, and you can see how far that hip was going out there, especially on the right, and at 50%. And then so I just did soft tissue lengthening because, one of the things is this kid was still showing us that he was progressing, he was learning skills. And so if I were to do bony surgery, I would set him back because he would then be weaker, he wouldn't be allowed to bear weight or anything. So we did soft tissue lengthening, and it bought us time until he was older. And he still hasn't had surgery yet. I think he's 6 now, and I am planning a surgery, like a bony surgery on him. But, I did not interrupt his progress with physical therapy and skill learning at this time. So I'm really happy we did this surgery because it bought us about 4 years before I'm now planning his surgery. When we talk about bony surgeries, bilateral VDROs, so varus derotational and shortening osteotomies and pelvic osteotomies, here's an example of it. The idea is to put the hips in the socket, make them more varus because normally you start with valgus hips when you're born, and as you grow and develop, they get a little more varus, and that doesn't happen in our kids with CP, and so we do these bony surgeries. This is just walking through that, doing the VDRO first, then doing a pelvic osteotomy, and you just put something in there to widen it and bring that roof flat to do a bony containment. And then that's what it looks like afterwards. When I say salvage surgery, that just means hip resection, meaning we just take out the hip because it's not helping, it's just causing pain. And so you can see here that it's not a great option. It does create a floppy leg, which makes it easy to diaper, but it can still, and it removes the immediate pain, but if your muscles are still tight and you still have that spasticity, that residual femur can still start hitting your pelvis and cause pain. So it doesn't eliminate pain in every child. So the key points is that hip surveillance is important. You should get a supine pelvis x-ray at the initial visit and continue to get x-rays. Please refer to us if there's any concerns, and the risk of hip dislocation is directly correlated to GMFCS level. Just remember 30 degrees or 30% in terms of migration percentage or lack of range of motion on abduction. And hip reconstruction is effective in improving positioning, mobility and transferring, comfort, and diapering. Oh my gosh, I need to speed it up. Okay, lower extremity issues in surgery. You can have deformities at each joint, the knees, the ankles, and the feet. We like to do SEMLs, which is single event multi-level surgery. That's when we just correct as many things as we can in one sitting, as if we can be safe doing it. And that eliminates the need for birthday surgery, which is like a surgery every year. We involve other specialists, such as our rehab colleagues, to do Botox on like the upper extremities while we're working on the lower extremities, or we have our plastic surgeons do transfers on the upper extremities. It reduces hospitalizations, it reduces periods of rehab. It's more cost effective, it's less disruptive to school and to parental leave from work. Knee flexion contractures, tight hamstrings, weaker quads, weak soleus. It has increased energy consumption, and we evaluate it using just like checking the popliteal angle and checking the contracture. There are different ways to address it. You can get 15 to 20 degrees of lengthening by just doing hamstring lengthening, plus or minus casting or bracing, and so this is just us lengthening the hamstrings. There's been a move towards growth modulation now. So what we do is we place screws in the anterior part of the distal femur to stop the growth anteriorly, which allows growth posteriorly. So you can imagine that can, over time, like over 2 years, so not immediate success, you can get about 20 degrees of correction. The last option, and this is actually a great option, but you are, the first two you can bear weight immediately. This last option, the distal femoral extension osteotomy, you just create a deformity to counteract the knee flexion contracture by hyperextending above it. That immobilizes the kid and doesn't allow them to bear weight for 6 weeks, but it is a great option in our kids who need to be able to stand for transfers and have the ability to do so, but have like significant knee flexion contractures. When it comes to the foot and ankle, our goals are to have braceable, painless, and plantigrade feet. Please note that that does not mean that we're going to do a surgery that prevents you from needing to wear a brace for the rest of your life. You will still need to wear a brace. And I often won't do surgery if a child will not agree, or the patient's family will not agree to be compliant with bracing afterwards, because then you'll put a kid through surgery, they won't wear a brace, and you will have done all this work for no reason. So I don't like, I like really screen kids out for that. This is a 20-year-old kid with a terrible spastic flat foot, and this is like one of the big reconstructions that we can do. This kid is non-ambulatory, but was having a lot of issues fitting into shoes. And this is a good 6-hour surgery. You would think it's a foot, so it shouldn't take that long, but there were 2 of us there, and we just took out the navicular. And you can see it already looks much better there. It's still swollen medially because now you just have this space where there used to be bone, and now it's just soft tissue, and you get a little bit of blood that collects there in the beginning. And then this was a couple months later. This kid's very happy. The family's very happy that he can fit into shoes. And so we can do something as impressive as that. It just takes a lot of time, and so we have to screen for the right patients who'd benefit from it. There is a high fracture risk in kids with CP, especially in those who don't walk, because they have low bone mineral density. There's sort of increased risk for fracture, especially if they have anti-epileptics, like they have seizures. They're unable to communicate sometimes when they have pain, and so Sometimes we get a diagnostic delay. And then when you immobilize them, they can't use their stander, they have decreased weight bearing and worsening osteopenia. So we have to be mindful of that. Just because they have hardware in, it doesn't mean they're gonna, that's not gonna cause a fracture. The problem is, this is one of my kids, he had that plate in for about 3 years, but if they're gonna get a fracture and there's hardware in, it's gonna be a periprosthetic fracture. And that's because of the transition from the stiffness of having metal in there to no metal. So if they're gonna break where the metal is. So I think goal setting is the biggest thing when it comes to surgery, especially in our more affected kids. We wanna help by providing a painless existence with reasonable positioning and no significant contractures that prevents like putting on clothing and taking care of them, shoeable feet, and different things to protect the caregiver, because that child's gonna grow and become heavy. And so it's important, even though we might see a problem, to actually ask the family what the problem is and how you can best help them. Sometimes it's small things, like you can see a bigger problem that you can address, but all the family really needs is like a small, minor change to make their day and their taking care of the patient easier and better. And so it should all be shared, realistic goals. The plan should be discussed. And I think orthopedic surgery is heavily reliant upon an interdisciplinary team, which at its minimum includes rehab, our therapists, orthotists, nutrition, and seriously much, much more. And again, your goals depend on your GMFCS level. We can improve gait. We can reduce some reliance on walking aids. Often you'll still be using braces. We can provide a little more symmetry for aesthetics. And then quality of life is the biggest thing when it comes to our GMFCS 4s and 5s. Preoperative optimization is a big thing. That's when you may hear from me. And we take a lot, we send out so many emails from our nurses here will contact you and ask you if you're worried about anything before doing surgery on our patients. And we rely on our pediatricians to lead a comprehensive review, identifying any issues of concern, communication, and if you think like there's gonna be an issue with follow-up or anything. And there's so many perioperative considerations. And sometimes we'll pre-admit before surgery to improve nutrition, to improve respiratory status, because nutrition, compromises wound healing and immune function. And so what we've found, and this is a retrospective chart review for pre-anesthetic clearance, is that if a pediatrician saw the patient prior to anesthesia's evaluation, then there was less likely to be last-minute changes in our plan that would then cancel the surgery. So for us, it's really important to get everyone involved. Lastly, there's a lot of access challenges for kids with CP. We work at a children's hospital, so we have a lot of resources for our kids who qualify. But even though CP is defined as a childhood disease, the life expectancy is quite long. And there are so many adults in the US living with CP now that many centers across the country, including UCSF, are building programs to help provide comprehensive care to adults with CP. But with that, we need more providers who are willing to provide that care. And they are looking to all of us who are in pediatrics to help with that, because a lot of adult providers feel like they haven't been trained since their residency years in cerebral palsy and other neuromuscular conditions. And so this is something that even the NIH has a task force dedicated to it. And so we would like to work on this more, and if anyone has interest, come up and talk to me. And so thank you for your attention, and I'll be answering questions.